So I had learned of a number of approaches that were quite effective, working intensively with people with OCD and anxiety. Like I just heard of the Bergen 4-day treatment for OCD that's going on in Norway. And I'd also become familiar with an approach called team CBT developed by Dr. David Burns that has a component of what he calls paradoxical agenda setting.
Welcome to OCD Whisperer Podcast. Today with me, I have Dr. Amy Huberman. She is a psychiatrist on the volunteer faculty at Johns Hopkins School of Medicine and in private practice in Maryland. She specializes in individually tailored psychotherapy and coaching for OCD, anxiety, and trauma, including intensive work that breaks free from the traditional 15-minute per work model. She offers psychotherapy for individuals located in Maryland and coaching to individuals worldwide. Welcome to the show.
Thank you. It's great to be here.
Yeah. So you and I met, I think it was the ADAA, was it?
That's right. Yeah. Spring of 2023, I think. Yeah.
Time really does fly.
Yeah.
Well, I know that, we connected just in general over, OCD work and, part of our conversation today, and I kind of mentioned to you right before we started recording, is that I actually have somebody on my YouTube channel who made this comment about medications for OCD and was saying things like, think that it should be a requirement. It shouldn't be a personal choice. Like everybody should be taking medication for OCD. I'm assuming probably also if it's severe OCD, but it really came across more like this person's opinion was that. And today what we're going to talk about is for you, as a psychiatrist, you mentioned that you actually decided to stop prescribing medication and really focus on psychotherapy. So I think that's just such an interesting moment and decision. And yeah, let's kind of dive into that.
Yeah, absolutely. And first, in response to that comment, I'm guessing that maybe the person who left that comment is someone who has really benefited from medication. And I just want to say that it makes sense to me that when you find something that really works, that you want that for everyone, right? That you'd want that benefit for everyone. And with that said, I'll also share sort of how I came to my decision as a psychiatrist not to prescribe medication. And I would say that it really goes back to starts with my residency training. That's where the seeds were planted. So I trained at Johns Hopkins, and there the message was very strong, exactly what that person said in that comment, that everyone with OCD or anxiety disorders or depression should receive medication. That was an essential component of the treatment. I learned to consider OCD as well as other anxiety disorders, depression, to be diseases. Think of them as sort of broken parts to the brain that sort of need to be fixed with medication. And I think even back then, there was a bit of me that was skeptical. I have had my own experience with anxiety and OCD, and there was a part of me that sort of resisted that way of seeing things. And yet, the message was so strong, and I did see people certainly feeling better than they were on medication. And really took that message away from residency with me. At the same time, one time in my residency training when I really saw patients fully getting their lives back, really recovering in a sustained and full way, that was in the few months when I received some training in cognitive behavioral therapy, and a psychologist who was very enthusiastic about exposure therapy came to take over our training. And under her supervision, I worked with a number of patients with severe OCD, severe panic disorder with agoraphobia. And I saw them in a matter of weeks go from really being restricted by the OCD or the panic, and going from that place to a place of living their lives again and really regaining agency. And that was something that I really didn't see, that regaining agency from prescribing medications. And that felt so meaningful and so fulfilling to me to sort of see, to sort of be a part of that process of guiding someone toward having their agency back.
And so just to clarify, because I'm sure, any person listening, like I know as clinicians and in the field, we use these words, right? But like, what do you mean when you say, somebody getting their agency back? What is that actually?
Yeah. So, I think so often with OCD, with anxiety, we can sort of feel like the anxiety or the OCD sort of has us. It's in control. And we don't really have much control, right? Like, especially in OCD, right? We feel like we have to do the compulsions. We don't have a choice. So agency is feeling that, no, I do have a choice. And that, that I really have some say in how I live my life, and whether or not I, engage in a compulsion or a safety behavior, or sort of live my life sort of ruled by anxiety, or making my own decisions.
Yeah, awesome. So you're saying that that's really what for you was one of those moments that made you kind of aware of like, wait a second, there's something else, and this something else seems like people are actually getting better in a different way. And so like, was that kind of the beginning of this thought of like, maybe medication isn't like the one and all?
Exactly. And in fact, starting from that time when really we just had a few months of once a week training in CBT and exposure therapy. Starting from that time, I actively started seeking out, outside of my training program, extra opportunities to learn psychotherapy and CBT, and really continued that after I graduated through now, still seeking out more opportunities for learning.
So I guess what made that change for you in your practice, where because I think it's kind of a big statement to make, right? Like, and again, for anybody listening, I do want to put a disclaimer there. Like, look, we're not saying don't take medication or only do this or only do that. It's not polarized like that. It's for some people, they might need a combination. For some people, they do really well on just therapy. Some people actually do really well with just some medication. Like there's variability here, but I'm really just curious for you, like where are you at with that, or what happened there that you really made that final decision of saying, you know what, I actually really want to hone in and focus on offering therapy versus.
When I left residency and sort of started my own practice, I, despite the fact that I was already so excited about psychotherapy, and questioning a little bit, at least the message that I had taken away from my training of medication must always be a part of treating somebody with OCD or anxiety. I did initially really feel that in order to be a responsible psychiatrist, I should prescribe medication. And so initially, I did prescribe medication to everyone who came to me, in addition to doing psychotherapy. And it was the case that some people, really experienced benefit, and some of some of them felt better. I no longer saw them after that. And so I don't know what, haven't had follow up to know how they did. I hope they're doing well. And what I noticed for the people who continue to see me for medication is that often what happened over the course of years, I prescribed medication for 14 years, was that a medication would really work very well initially, and then they might experience something called the poop out effect, where basically the medication sort of loses efficacy over time. And then often we would either, try going up on the dose or switch to a different medication. And often it was actually hard to sort of get that same benefit again. This wasn't the case with everyone, but there was this pattern where for so many people this was happening, as well as experiencing significant side effects on the different medications, which actually isn't surprising if you think about how they work. Basically increase the availability or the activity of certain neurotransmitters that affect multiple neurocircuits in our brains, and not just in our brains, in our various organ systems. So it makes sense that they produce side effects, and they're sort of like using a broad brush to paint fine detail in a painting. Like you can get the colors in there, but you get other things painted too. There's a neurobiologist at University of Rochester, Mark Noble, who has described really good psychotherapy that's tailored to an individual as microneurosurgery, because it can really target, the specific neural pathways that are relevant to someone. When the big qualifier there is that it does have to be well done and really individually tailored.
So for you, like with all of that experience, sounds like initially was medication and therapy, and then with enough time, you noticed that, or it seems like, did you notice that the therapy piece became like more important, or what was that like, right? Because again, remember, we're talking about OCD, right? And for right. The audience here, it is OCD folks, right? So I already know, like, I mean, I have OCD myself, like, but I could feel it, I could hear it. Anybody listening to this will be wondering, like, oh my God, am I doing the right thing? Should I be on a medication? Should I not be on medication? Is it good? Is it bad? Right? All that kind of mental analysis that begins with this process. And again, this is your journey of how you're perceiving it. But yeah, like, so what happened there where you said, okay, I was prescribing, and then suddenly I saw something else where I'd made a decision to focus much more on the therapy component.
So, and again, I do want to say, right, some people did find benefits, and I agree with everything you just said. But yeah, so what I saw, at the same time that I was seeing how for many people, medications lost efficacy and it was hard to find another one that worked quite as well, et cetera, was that the people that I really saw, again, just as in residency, sort of the people that I really saw finding meaningful and sustained benefit from our work together, when I asked them for sort of feedback about sort of what was helpful, it tended not to be the medication. Right? It was again and again, it was discovering that I can, that I don't have to do the compulsions, that I can face my fears. Some feedback has just been seeing myself as whole rather than broken. That's really sort of what made a difference to me. And so I saw over time that the things that people were telling me was most helpful to them were not actually the medication pieces, but the psychotherapy, and which has honestly always been the part that I really loved about working with patients. And so in 2020, when sort of everything was turned upside down by the pandemic and my son was suddenly at home all day, I couldn't sustain the practice that I had going. And I knew that I had to make a change. And I had been thinking for a number of years, wouldn't it be so nice if I could just focus on psychotherapy, the piece that I love? And in the meantime, I'd also become excited about the possibility of working with people in an intensive way. So I had learned of a number of approaches that were quite effective working intensively with people with OCD and anxiety. Like I just heard of the Bergen 4-day treatment for OCD that's going on in Norway. And I'd also become familiar with an approach called team CBT developed by Dr. David Burns that has a component of what he calls paradoxical agenda setting that really helps with dealing with the reluctance that all of us have to making changes that I know that I've certainly had and continue to have in my own journey with anxiety and OCD. And that really helped make possible sort of more rapid change. And so I got really excited about this possibility of just redoing my whole practice, switching over, no longer prescribing medication, and actually offering intensive psychotherapy. Initially, that's all I did after I made the switch. I'm now offering also more traditional once a week sort of psychotherapy as well.
That's awesome. I mean, honestly, what that sounds like is like a journey of these, like anything in life, right? Like once you become aware of something and then you learn it and kind of deep dive into it. And then that newfound understanding, insight, perspective, like you said, the Bergen, 4-day intensive, and then the team CBT, of course, exposure response prevention, that kind of wrapping your mind around all of that and seeing that these things offer a way, a different way. And and then you just kind of went with it. And I mean, I think that's beautiful. I will say there aren't, at least not for me, I don't know a lot of psychiatrists who really embrace and take on the psychotherapy component, right? Like in this field, there's like, marriage family therapists, they do psychotherapy. And then, there's psychologists, they do assessments. And then there's, psychiatrists and MD, okay, they prescribe, right? And it's just interesting. Those are usually the delineations versus, I think, when you do understand the full scope of all the components, being able to also notice that a lot of things, at least this is what I anecdotally have found, is helping people understand themselves better, right? Helping them understand what is actually happening to you so you can make sense of it so that you're then not scared of it or that part of yourself, which helps then that acceptance piece and going, oh, okay, now at least I know, or I get it, or I have a way to understand it so that then I can interact with it differently.
Exactly. Yeah. Even that piece just of understanding and acceptance, right, shifts someone from being in that role of feeling like, the OCD has control to a different relationship with it.
Yeah. And actually, that's the thing I wanted to ask you, because I know as you're saying, like kind of your journey of kind of this discovery and then making this change, and part of it, of course, circumstantially like 2020 and then to present time and adjusting. And would you say, like, when you're looking at for yourself, when these changes would occur? Because I mean, that's always a common question for people with OCD, right? Is how do I get back to being myself, right? How do I get back to accepting myself or accepting myself with this thing? called OCD, where I might have violent intrusive thoughts, or I might have violent thoughts of sexual nature, or anything like that, or things that are morally just, we find difficult and challenging. Like, what would you say is the biggest piece of the therapy process that you've found helps people get that shift or get to that place of, right? Is it the doing a ton of ERP? Is it the psychoeducation? What is it?
Yeah. So getting people, am I right in understanding you're asking sort of what is it that gets people to that place of self-acceptance?
Yeah, because they were mentioning that's one of the things that really was awesome that you got to see, where people kind of re-engage with that ability to understand themselves better, right? Have more peace, have that agency we talked about. So what have you found, if you were going to say, like, what's the one thing? Maybe there isn't just the one thing, but just for the purpose of today, like what would you say if you're going to think about, okay, if I was going to prioritize this is one big element that seems to be important?
Yeah. So it is hard to choose because I'm thinking of three things. But
okay, what are they?
So one is a piece that I've taken from Dr. Burns's team CBT, part of that paradoxical agenda setting. And that is actually understanding what it is that our symptoms, actually even like to use the word symptoms because those same symptoms can mean something really good about us. And that's actually the point here is sort of understanding what our symptoms say about us, reveal about us. That's actually really important and positive. So for example, right, somebody who has obsessions, harm obsessions, really afraid of, killing a loved one, for example, right? Sort of looking at what does it say about you that, right, this is what you're most afraid of. What does it say about what you value? And so I'm sure you can make some guesses, right? That, right, it tends to be exactly the things we most value that we're afraid somehow hurting, losing, right? In inference-based CBT or ICBT, I feel like there's a very similar process when we move from, shifting from looking at the vulnerable self theme or feared possible self to the real self. Seeing that the feared possible self is actually the opposite of the real self. And they're really connected through these values.
So you said there's three things, and would you mind just naming what are the other two? Curious.
So actually that was two, the inference-based CBT, and then the paradoxical agenda setting, which includes this sort of positive reframing of our symptoms to see what they reveal about our values. So that's two things. And then the third I really feel is just, and this very relevant, I think, in any of these therapies, including exposure and response prevention, is just having that experience of seeing, right, when first of all, that I can sort of face what I'm really afraid of. And also, sort of seeing from that process itself can reveal, right? When I
quite a bit
hold a knife up to my loved one's neck and I don't do the thing that I think I'm going to do, that process itself can reveal, oh, right. It reminds me, this is actually the person I am, somebody who would never want to do that.
I love it. Thank you so much for sharing those. I mean, I think those are extremely valuable. And I love that you actually threw in there also ICBT stuff. And I mean, like everything these days, I think my big stance is, hey, whatever helps the person get better. But
Exactly.
I love those. Yeah. Thank you so much for coming and for sharing all this. And if people who are listening today would like to find you, how can they find you?
Yeah, so I have a website. So it's www.amyhubermanmd.com. That's probably the best way. I can also be reached at theanxietydoctor@amyhuberman.org.
I love it. And of course, I'll include that in the show notes. Thank you so much for coming on today.
Oh, thank you, Kristina. It's been a pleasure.